Hello students, the neck for the convenience of the students, teachers, surgeons and physicians. The study of the neck has been done by various landmarks. So you can see this one is the front of the neck, and there is a back of the neck and side of the neck. Neck can be studied from the frontal aspect. All the important structures are there in the frontal aspect, and laterally there are also important structures, and posteriorly only the muscles, some lymph nodes and the smaller nerves are there in the posterior aspect, and the muscle trapezius that makes the cut of your shoulder here, the shoulder posteriorly coming from the occipital bone and is inserted on the upper lip of the spine of the scapula, that posterior aspect of the neck. Now neck can be studied from the frontal aspect as well as from the lateral or the side of the neck. So some of the important landmarks regarding the neck, study of the neck. For the convenience of the students, teachers, surgeons, we have imaginary divided the neck into some triangles that we are going to study today, the anterior and posterior triangles of the neck. So before starting, we should know some important landmarks of the neck. So this one is the symphysis pubis. Here is this one is the base of the mandible. This is angle of the mandible. Laterally and posteriorly there is a parotid gland anteriorly at the lateral and posterior aspect of the angle of the mandible. This one is also called, in our civil language, is called as a chin. So here to the base of the mandible, the beauty of the face, especially in case of females, as all of you know better, the neck is one of the neck has a cosmeticity, especially in the females. There are hairs on the just below to the mandible due to the, it is one of the secondary sexual character of a male. So one must keep in mind the beauty of the neck. So as all of you know the history, the beauty of the neck, the history of that Mastani, when she was eating something, especially the pan, and when she was degluting like this, that borders of a food can be seen better due to the transparency of the platysma muscle. So skin is there, undercover of the skin, undercover there is adherent platysma muscle is there, which gives, and it is one of the translucent and transparent muscle. It is very thin muscle in the body, very thin muscle. During the surgical operative, surgeon must have to take care that the cosmeticity of the platysma should not be disturbed by keeping it intact. Otherwise, post-operative wrinkles will be there if anybody is operated for the surgery of the neck. So post-operative wrinkles may be there due to the without taking the care of the muscle platysma. So first one, angle of the mandible, pubis symphysis, and this one is the chin. This is the base of the mandible. This is the base of the mandible. Here above the sternum there is one notch. One notch is there, and that notch is being called as a suprasternal notch, or suprasternal means above the sternum, and also called as a jugular notch. This one is called as a jugular notch. Above the clavicle here, above the clavicle here, there is a supraclavicular fossa. Here is this supraclavicular fossa is important because many vital structures are located. And why this is called as a jugular notch? Because that internal and the jugular vein is very nearer in this jugular notch. Then the sternocleidomastoid. The muscle itself suggests the origin and insertion. The sternocleidomastoid on both. So neck is being studied right side and left side separately. This is the midline of the body from the symphysis pubis, from the base of the mandible till to the jugular notch. You have to divide the neck into two parts, right sided and left sided. And this sternocleidomastoid, you look carefully, this muscle, sternocleidomastoid. The muscle suggests that it origin from the sternum. This is the sternum. This is the sternal origin, sternocleidomastoid. It gets origin from the manubrium sterni. It ascends upward and is inserted back to the ear on the superior nuchal line, posterior and superior to the mastoid process. This bony prominence is called as the mastoid process. Interiorly, it consists of the air cells. As you know, if you have been studied the middle ear cavity, behind the middle ear is mastoid air cells. It is filled up with the air cells. So this one is called as the sternocleidomastoid. This muscle is important. It divides the side of the neck into anterior and posterior triangles. Anterior and posterior triangles of the neck. So external jugular vein. You can see here external jugular vein here in the jugular notch. Secondly, the greater supraclavicular fossa. Then the transverse process of the atlas vertebra can be palpated. Transverse from the angle of the mandible. If you palpate with your index finger, you will get the transverse processes of the mandible in a person in whom the muscles are powerful. It is difficult to palpate the transverse processes of the transverse process. Actually, atlas is a ring-like muscle. The transverse processes are very short. You can palpate it from the just below to the angle, at the level of the angle of the mandible. Then the fourth cervical vertebra, the process palpable at the level of the upper border of the thyroid cartilage. This one is a thyroid cartilage. You can see the transverse process can be palpated of the fourth cervical vertebra at that level. Then the anterior tubercle of the sixth cervical vertebra can be palpated at the largest of all the processes, called as the carotid tubercle of the chassigny. Then the anterior border of the trapezius. You can palpate the trapezius. It gets originated from the superior nuchal line. You can palpate. See that elevation of the shoulder. If you elevate your shoulder joint, the prominence of the trapezius muscle can be easily found. So it has a anterior border. This one anterior border of the muscle trapezius. So these are some important landmarks. This one is called as the Adam's apple. It can be seen the prominence of the thyroid cartilage. This one is a thyroid cartilage. The thyroid cartilage can be is more to be prominent, especially in the youngsters, and that depends on the person to person. Enlargement of the thyroid gland, growth of the thyroid gland, and enlargement, especially change in the vocal cords, enlargement of the thyroid cartilage, and prominence of this thyroid cartilage is called as the Adam's apple. Okay, now the boundaries, side of the neck. See, side of the neck can be bounded here from the symphysis menti to the jugular notch, and this is the base, and This is base. It runs towards the superior nuchal line and anterior border of the trapezius. You got anterior border of the trapezius, and here is the base of the posterior triangle. Posterior triangle is directed upward. For the convenience of the students, we have divided the triangles into students and even for everybody to understand the complicated structure of the neck. We have divided it into anterior triangle and posterior triangles. Now, the side of the neck is roughly quadrilateral in shape, outline bounded anteriorly by the anterior median line and posteriorly by the anterior border of the trapezius. That is quadrilateral, basically, not triangular, quadrilateral in shape. Quadrilateral in shape. And the quadrilateral space is divided obliquely by sternocleidomastoid, as just I have told, into anterior triangle and posterior triangle. So, first of all, the skin of this anterior aspect of the neck. See, skin of the neck is supplied by the second, third and fourth cervical nerves. Then the anterior lateral part is supplied by the anterior primary rami through anterior cutaneous and great auricular, lesser occipital and supraclavicular nerves. A broad band of skin over the posterior part is supplied by the dorsal posterior primary rami. First cervical spinal nerve has no cutaneous distribution. Cervical 5th, 6th, 7th, 8th and thoracic first nerve supply the upper limb through the brachial plexuses. Therefore, do not supply the neck. The territory of the fourth cervical nerve extends into the pectoral region through supraclavicular nerves and meets second thoracic dermatome at the level of the second costal cartilage. Now, that is regarding the skin nerve supply over the neck. Now, superficial fascia. This superficial fascia. The superficial contains a areolar tissue with platysma. See, the line deep to the platysma are cutaneous nerves, superficial veins and the lymph vessels, lymph nodes and small arteries. The clinical importance of the platysma. See, just I have told, so surgeon has to take care during the operative process of the neck that it should be well separated from the skin. See, surgeon has to stitch platysma muscle separately so that the skin do not adhere to deeper neck muscles. Otherwise, the skin will get ugly scar and will get wrinkles after post-operative. The cosmeticity of your neck will be drastically deranged due to that wrinkling on the neck. If the surgeon do not take care to separate the platysma muscle from the deep fascia. So, then skin superficial fascia with platysma, deep fascia consists of the it is important in case of a neck. Deep it has a from outside inward investing layer, pretracheal layer, prevertebral layer, carotid sheath. There is a special sheath that is derived from the deep fascia that covers the carotid artery and jugular vein, vagus nerve and hypoglossal nerves. That is, and cervical trunk remains outside. But these structures, vagus, carotid artery with its bifurcation, internal carotid artery, external carotid artery, jugular vein and the hypoglossal nerve and vagus nerve. These four structures are specially covered by the deep fascia derived from the neck, and that is called as a carotid sheath. Then the buccopharyngeal fascia. Buccopharyngeal fascia towards the medial side or towards the pharynx. Then the pharyngobasilar fascia. These are the fascias derived from the deep fascia of the neck. The investing layer, it lies deep to the first from outside inward. These 6 fascias are there. Again, investing layer, again revise. Investing layer, pretracheal fascia, prevertebral fascia, carotid sheath, and the buccopharyngeal fascia, pharyngobasilar fascia. The name of these fascias are according to their structures covered by it. For example, the carotid sheath, that is a sheath derived from the deep fascia of the neck that covers the carotid artery, jugular vein, vagus nerve and hypoglossal nerve. Now, where this deep fascia is being attached, after removal of the skin and platysma, there is a deep fascia. How it is above it is attached and how it is below attached. Superior attachment and inferior attachment. Superiorly, it is attached to the posteriorly external occipital protuberance. Secondly, to the superior nuchal line, external occipital protuberance, then superior nuchal line, mastoid process. This one is a mastoid process. You can see here the mastoid process. Then the external acoustic meatus. This one is a external acoustic meatus. From here, this deep fascia starts, then the base of the mandible. From all of these structures, the deep fascia starts and descends downward, and it overlaps to the some interior structures like carotid, then the pharynx, some parts of the pharynx, then the basilar part, then the tracheal part, that fascia derived from the pretrachea, before the trachea or above the trachea. Then this deep fascia descends downward and it descends downward, and basically it sends some backward fibers are there to adhere or to get attached to the spine of the scapula. Then the clavicle, anteriorly clavicle, posteriorly the spine of the scapula, then acromion. This one is the acromion, the bony prominence on your shoulder. It is undercover of the skin. That is acromion, and the manubrium sterni. Manubrium sterni, this one is the manubrium sterni, the upper part of the sternum, a quadrilateral part, manubrium sterni. Here to the clavicle, to the spine of the scapula, then acromion. So it descends downward and is attached to these parts. So this is attachments of the deep fascia of the neck. Then the deep fascia may get anteriorly, posteriorly it is attached to the ligamentum nuchae, spine of the 7 cervical vertebra. Anteriorly it is attached to the symphysis menti. This one is the symphysis menti. Then here it is attached to the hyoid bone medially. Medially it is attached. All of these deep fascia medially attached to the hyoid bone. Then other features of this investing layer. Investing layer, the muscles undercover of that, trapezius, then the sternocleidomastoid, salivary, it covers the salivary gland also. Salivary gland, especially the submandibular, sublingual and the parotid gland, it covers. Then the suprasternal space, it also the right and left sternocleidomastoid, jugular venous arch, the jugular vein, lymph nodes, submental lymph nodes, it covers. Then the intraclavicular ligament, supraclavicular space, then the cutaneous vessels, supraclavicular nerves and external jugular vein. It also forms a pelvis to bind the tendons of the digastric. Here to the digastric, here anterior belly of the digastric and posterior belly of the digastric, and that is the mandibular ligament also. Then the paramacetic vessels, parotid and macetic veins or the fascia. Now in this region, what are the common things? Clinical anatomy, very simple. First of all, the mumps. This is a region where the parotid swelling is very common. When you excise submandibular, what is submandibular? Below the mandible. We will separately study the submandibular region, but this submandibular region is salivary gland, external carotid artery should be secured before dividing it, otherwise it may retract through the stylomandibular ligament and cause serious bleeding. So care should be taken that when you are exposing the carotid triangle or when you are excising the submandibular, especially below the mandible, digastric region. The care should be taken because this carotid artery is very near. So especially for the new growth, the operative of the new growth, the care should be taken that the carotid artery should not be injured during the operative of the submandibular region. Then missingly during the operative process, there may be a chance of that injury to the carotid artery, and that becomes dangerous. Then the division of the external jugular vein in the supraclavicular space may cause air embolism and consequent it is dangerous it should be prevented, and retraction and closure of the fascia attached firmly to the vein. So that vein, external jugular vein, may get embolized. May get that condition is not so much common. Vein may get embolized. So then the pretracheal fascia. The pretracheal fascia is that encloses, suspends the thyroid gland. Pretracheal fascia means before the trachea starts. Pretracheal fascia that encloses the thyroid gland, and that is a false capsule. That is nothing but the false capsule of the thyroid gland. It is that pretracheal fascia superiorly attached to the hyoid bone here. Then the oblique line of the thyroid cartilage laterally and cricoid cartilage more laterally. Inferiorly, that pretracheal fascia below the thyroid gland, it encloses the inferior thyroid veins, passes behind the brachiocephalic veins, and finally blends with the arch of the aorta and fibrous pericardium. On either side, this pretracheal fascia in front to the carotid sheath and fuses with the deep fascia of the sternocleidomastoid. Here, the laterally, anteriorly and laterally, medially and laterally, attachments of the pretracheal fascia. On other features, posterior layer of the thyroid capsule is thick. On either side, it forms the suspensory ligament for the thyroid gland, which is known as the ligament of the Berry. Then the fascia provides slippery surface for a free movement of the trachea. See, if you move, it moves freely. For that fascia freely moves around the thyroid gland or the trachea also. So that directly do not adhere. So there is a free movement of the deep fascia or pretracheal fascia of the neck around the thyroid gland as well as to the trachea. Pretracheal fascia. Now, neck infections in front of the pretracheal fascia may bulge in the suprasternal area to extend down into the anterior mediastinum. So infections in this neck may enter into the anterior mediastinum, anterior to the heart. Then the thyroid gland and all thyroid swellings move the deglutition because of thyroid is attached to cartilages of the larynx by a suspensory ligament of the Berry. Then prevertebral fascia. The name itself suggests what is prevertebral fascia. It lies in front of the prevertebral muscles. It forms the floor of the posterior triangle of the neck. Attachments: prevertebral fascia superiorly attached to the base of the skull. Prevertebral means it is interior at the base of the skull. Then inferiorly it extends into the superior mediastinum, where it splits into the anterior and posterior layers. Anterior layer, alar fascia blends the buccopharyngeal fascia, and posterior layer attached to the anterior longitudinal ligament and the body of the fourth thoracic vertebra. That is prevertebral fascia. Then we have seen pretracheal fascia inferiorly, and from the base of the skull that fascia is derived and it is attached to the vertebra, especially to the vertebrates. Anteriorly it is separated from the pharynx by buccopharyngeal fascia by the retropharyngeal space containing loose areolar tissue. In the lower part of the neck, prevertebral and buccopharyngeal fascias fuse, and laterally it is attached to the trapezius and attached to the fascia of the sternocleidomastoid. trapezius and sternocleidomastoid. The other feature, cervical and brachial plexuses lies behind the prevertebral fascia, as the trunks of the brachial plexuses and subclavian artery passes laterally through the interval between the scalenus anterior and scalenus medius. Scalenus anterior and scalenus medius in the supraclavicular triangle, in the scalenus anterior and scalenus medius. Fascia provides a fixed base for the movement of the pharynx, the esophagus and carotid sheaths during movement of the neck and during soli. Now, some of the important clinical points regarding the neck. Neck infections behind the prevertebral fascia. Now, we have seen the anterior aspect of the neck and lateral. Now, infections in the deep, starting from the base of the skull. Prevertebral fascia arise usually from especially the tuberculosis. Tubercular infections are very common, and there is an enlargement of the, especially tuberculosis of the vertebrae that or cervical caries. The pus produced in the result may extend in various directions. It may pass forwards, forming a chronic retropharyngeal abscess, which may form a bulging of a posterior wall of the pharynx in the median plane. The pus may extend laterally through the axillary sheath and point in the posterior triangle or in the lateral wall of the axilla. It may extend downward into the superior mediastinum, where its descent is limited by fusion of a prevertebral fascia to the fourth thoracic vertebra. So, in the deep to the prevertebral fascia, in the deeper part to the vertebra and to the base of the skull, if any infections, they may form the retropharyngeal abscess behind the pharynx. The pus may come stored or accumulate, bulge in that behind the pharynx. That is retropharyngeal abscess. If it descends downward, it may reach towards the superior mediastinum. It may reach towards the superior mediastinum. Then it may reach to axilla also, the lateral wall of the axilla downward. So then especially the suppuration. Suppurative infections may spread into these deeper structures of the neck. Now, a carotid sheath. The name itself suggests what is carotid sheath. Carotid sheath is a condensation of a fibroareolar tissue around the main vessels of the neck. The carotid artery, bifurcation of the carotid artery, internal carotid artery and external carotid artery, and medially the jugular vein and vagus nerve. Jugular vein and vagus nerve, and outside there is a sympathetic trunk, and anteriorly there is a small chain of nerves called as the ansa cervicalis. Basically, the vagus, jugular and carotid artery, vagus, jugular vein and vagus nerve is covered by sheath. It's called as a carotid sheath. How it is formed? It is formed by the anterior aspect of the pretracheal fascia, just we have discussed, and the posterior aspect of the prevertebral fascia. Anteriorly pretracheal fascia and posteriorly by prevertebral fascia. And the contents, it consists of three things only: carotid artery with its bifurcation, jugular vein and vagus nerve, and ansa cervicalis and sympathetic trunk remain outside that sheath. So that is one of the important sheath and important structures. The contents we have seen. Relations: ansa cervicalis lies embedded in the anterior wall, and posteriorly there is a vagus nerve inside the sheath, and posteriorly there is a sympathetic trunk outside the sheath. So these are the structures. We have also discussed the buccopharyngeal fascia and pharyngobasilar fascia. These are the fascias, various fascias. 6 fascias are derived from the deep fascia, prevertebral. We have seen the embedded 6 deep fascias, investing layer, then the pretracheal fascia, prevertebral fascia, carotid sheath, buccopharyngeal fascia and pharyngobasilar fascia on the basis of the names. See, buccopharyngeal fascia to the buccal cavity, towards the about to the buccal cavity and to the pharynx, and the pharyngobasilar fascia, it is one of the pharyngobasilar fascia is especially thickened between the upper border of the superior constrictor muscle of the pharynx and base of the skull. It is so deep, pharyngobasilar fascia, and it lies deep to the pharyngeal muscles. So these are the various 6 deep fascias of the neck. The pharyngeal spaces, there are 2 important pharyngeal spaces. One is the retropharyngeal space and lateral pharyngeal space. This retropharyngeal space is a common site of the pharyngeal, the retropharyngeal abscess produced in the prevertebral fascia, in the structures of the at the base of the skull and vertebra. Any abscess or infections of the neck that comes into the retropharyngeal space.